Hey guys, and welcome back. We're going to go ahead and continue with questions 16 through 20 on the ANCC sample test for November of 2019. Okay, so let's begin. Number 16. A patient who has been in the ICU for 17 days develops HHNK. The patient weighs 132 pounds, is intubated, and is on the vent. The serum osmo is 320 milliosmoles per liter per kilogram of water. Clinical signs include tachycardia and hypotension. The nurse practitioner's initial treatment is to A. Reduce the serum osmo by infusing 5% dextrose and 2% sodium chloride solution. B. Reduce sodium concentration by infusing a half normal saline solution. 3. Replenish volume by infusing a 0.9 normal saline solution. Or replenish by infusing a 5% or D5W solution. All right, so this question is a bit tricky. So let's take a good look at it. It's trying to distract you with a lot of information. So let's get down to the nitty-gritty. We have a patient who is in the ICU. That may or may not have a lot to do with it, but we know it's a patient that is critically ill for a period of time. Doesn't matter if it's 2 days or 17 days. They have developed HHNK, hypernatremic hyperosmolality. The patient weighs. All right, nurses and math. We're not going to do math. Distractor question. Don't worry about it. He's intubated. Doesn't matter. Distracted question. And is vented. Distractor. Their serum osmo is 320. Clinical signs, which is important, include tachycardia and hypotension. What do you do? What do you do? So, when I first looked at this question, my thought was, well, what's the sodium? Now, Barkley in his class, if you guys take it, will say that the serum osmo is usually around half the sodium. So if we cut this in half, that would be 160. And we say, holy crap, that's really high. And what should I do? I gotta do something. We know that they're tachycardic, so heart rate greater than 100, and hypotensive, meaning blood pressure is less than 90. So going back to so basically it's asking us, we're going to give fluid. What's the initial fluid you give for a person who's in HHNK? Is it 5% with 0.2? Is it half normal? Is it 0.9 or D5W? Okay, because reducing the serum osmo is the same as, you can reduce the serum osmo and reduce the sodium concentration in a couple of different ways, but it usually involves giving fluid. So these are all distractors. Whether we reduce serum osmo, reduce serum sodium, or replenish volume, okay, it all means the same thing. We know that they are intracellularly, or that we know that they're intracellularly dry, and we need to give fluids. That's all these say, okay? The question is, what is the first treatment for HHNK when it comes to fluid? And of course, we'll look back at our flow sheet, and looking at it, we go to IV fluids, determine hydration. Excuse me. And we look at this, are they in hypovolemic shock, mild hypotension, or cardiogenic shock? We know that they're hypovolemic. Always, you give the first liter is always 0.9% normal saline. So regular normal saline is what you give. 0.9 NS is always the first fluid of choice. Very rarely do we give anything else, and it's usually we give something else when they are hyponatremic. If they are hyponatremic, meaning a sodium usually less than 120 or less than 115, and we know that their brain's herniating out their back of their skull, that's when we give like the 0.3% saline solution. When they're hypernatremic, we know that we're estimating somewhere in the 150-160 range with the serum osmo of 320. We want to give fluids, and we want to give something with some sodium in it. Almost always the first fluid of choice for either DKA or HHNK is usually 0.9 saline. Then we reassess and we either continue with the 0.9 or give half normal. But the initial is always 0.9 normal saline. Okay? 17. 32-year-old patient who underwent an open splenectomy for a ruptured spleen is preparing for discharge. The nurse practitioner reviews the complications with the patient. The nurse practitioner emphasizes which instruction to the patient. Okay. Continue antibiotics for 14 days. Follow up with a PCP for vaccinations. No international travel for 5 years. And no weightlifting restrictions. Okay. So, person had an open splenectomy, not a laparoscopic, but they cut their abdomen open. They have like an 8-inch incision over their left upper quadrant. So fairly large. Okay, so let's look at what we can throw out first. We know they have that large incision, so of course they're going to have weight restrictions because they have this open incision in their belly that they had to cut open their abdomen for. So of course you're going to have weight restrictions of like 5 pounds for the next couple weeks. They're going to be feeling pretty sore. So that is definitely a toss. Okay. Continue antibiotics for 14 days. That's probably going to be another toss because we don't know this patient's infectious. We typically don't give prophylactic antibiotics for 14 days unless there's an infection. So continuing antibiotics just for the heck of it is definitely a tosser. So we're going to toss A, and we're going to toss D. Now let's think at our pathophys. What does the spleen do? It's one of its main functions is the immune system. It holds all of our B cells for immunity. So, with that in mind, follow with PCP for vaccinations or no international travel for 5 years. Okay, why is it coming up with this 5-year business? I don't know. Why would international travel be banned versus local travel? There's something about foreign bugs that could get someone? Possibly. Is it more so in a person without a spleen? It's kind of iffy. So it looks like it's probably going to be more of follow-up with PCP for vaccinations. You look at the guidelines, which I found, post-splenectomy vaccine prophylaxis. Okay, so when we're looking at vaccine prophylaxis, it says right here, splenectomy patients should be vaccinated electively 14 days prior to the operation. That's if they got a tumor or some sort of weird thing going on in their spleen that has to be removed. Usually not traumatic, because traumatic is usually an emergent splenectomy. People who are immunocompromised should be vaccinated as soon as the diagnosis is made. Pediatric vaccination should be performed according to guidelines. When an adult has a spleen removed, they should get the following vaccinations. They should get Pneumovax 23, which is the big one. They should be immunized against H. flu type B, as well as meningitis. So that is the correct answer. They should be vaccinated with the PCP. Probably should have been done in the hospital, but as we're going over discharges, if that hasn't been done, that needs to be done. They need to get vaccinated. So that is the correct answer for 17. All right. Number 18, 40-year-old female patient with no previous medical history is admitted with bilateral PE. During the workup, they have positive lupus, and she needs to be on lifelong anticoagulation therapy for this. Patient verbalizes concern about her ability to manage appointments and follow-up care. The nurse practitioner's most effective intervention is to A, arrange follow-up appointments with the patient at the Coumadin clinic and with the PCP after discharge. Okay, so make the appointment. B, engage in active listening. Reassure the patient that she'll be able to manage her own care. Important, yep. C, reassure the patient that Coumadin therapy is quite manageable and requires infrequent follow-up visits. Well, we know that's not true. We know that anytime you do Coumadin, you have to have monthly INRs at a minimum. Sometimes people have, their home INR machine that they check up. Sometimes when they're really good with it, but at least initially, they're going to have to be in the clinic at least once a month. So we can toss C right away. And then D, reinforce the patient that typically patients with positive lupus only need Coumadin for 6 months. We know that's not true because they have lupus. Okay, that is a lifetime of anticoagulation because they will always have lupus anticoagulant. So anytime the patient has lupus, doesn't mean if it's active or in remission or quiescent, they're always going to have chronic Coumadin anticoagulation because you don't know when it's quiescent and when it's active. And she's always going to be at risk for PEs. So that's how we got rid of our last two. So we know that these two are not correct. So our next choices: arrange follow-up appointments for the patient in the Coumadin clinic, or B, engage in active listening and reassure the patient that she'll be able to manage her own care. Both of these are things you should do. Yes. Most effective. Okay, so whenever it says most effective intervention and it comes with, discharge planning, the answer is always going to be arrange outpatient appointments for the patient. That is, if you make the appointment on their discharge, say you need to be at the Proton clinic, 8 a.m. on Tuesday, be there, be square. They will most likely make that appointment. If you leave it up to the patient and make their own appointments, they'll say, no, I got such and such 8 o'clock on Tuesday, maybe next week, next 2 weeks, we can arrange it then. And they get out of the system and then they don't follow up and then they don't take their Coumadin and they lose that reinforcement and then they are under anticoagulated and they come back with even more massive PE. So this is the most effective intervention of the two. Of course, engaging in active listening, reassuring is all well and good and should be done, but the most effective is going to be A. All right, 19. 68-year-old patient who had surgery 3 days ago to repair a AAA. The patient is intubated, but is neurologically intact and has active bowel sounds. The patient's liver function is within normal limits, and the patient has no signs and symptoms of heart failure. And the lab values are BUN of 12, creatinine of 0.8, PCO2 of 37. The preferred form of nutritional support for this patient is Dobhoff tube, G-tube, parental nutrition, so PPN via a large bore catheter in the arm, or TPN with a central line. Okay, so let's look back at the root question and tease this apart. Patient had surgery 3 days ago. He's intubated. He can't eat. Neurologically intact, doesn't matter. Has bowel sounds, that does matter because from the bowel sounds, we know they have an active GI tract that is working. This is confirmed by their LFTs are normal. Okay. No signs or symptoms of heart failure, distractor. BUN, distractor. Creatinine, distractor. Bicarb, distractor. So we're looking at how should we feed this intubated guy? Should it be with enteric feedings or enteral feeding or parenteral feedings? Okay, so remember, enteral feedings is tube feeds. We're passing it into the stomach or the GI tract for the GI tract to absorb itself, or we're giving feedings through the IV, either with peripheral parenteral nutrition or TPN. The way you decide is do they have an active GI tract? If they have a functioning and active GI tract, you almost always go with enteral feedings. If their GI tract is not active, then, for example, if they had a total colectomy and they their GI tract isn't working, they can't poop, and their colostomy bag is immature and they can't use it, or if they have whatever reason they can't use their GI tract, that is where we use our TPN and PPN. This gentleman has an active GI tract, so we know we can get rid of these last two. We don't need PPN, we don't need TPN because he has an active GI tract. Next, we have to figure out which feeding to use. So our choices are nasogastric small bore tube, or otherwise known as the Dophoff, or a G tube. The question is, do we expect this guy to come off the vent? Okay, looking back, now what I said was a distractor isn't actually a distractor. They are neurologically intact. Okay, so it's not like he had a massive stroke and we're expecting him to sit in like long-term nursing or nursing home for the rest of his life. He is neurologically intact. His labs look good. Everything else looks good. It's just that he remains intubated for whatever because of his AAA. So we know we're expecting him to get off the vent relatively quickly. So the guideline is, if you're going to need feeding for greater than 6 weeks, that's when you do a G-tube. If it's less than 6 weeks, we do the Dophoff. Or they can't use Dophoff, it'll be small bore tube. So less than 6 weeks, we use the Dophoff. Greater than 6 weeks, we use the G-tube. So the answer is going to be A. All right, and number 20, our last one. 70-year-old patient with acute systolic heart failure denies any functional limitation, is able to walk 5 blocks before tiring, and is euvolemic. Which medication is the first-line therapy for this patient? And our choices are amlodipine, which is a calcium channel blocker, digoxin, Lasix, which is our diuretic, and lisinopril, which is our ACE inhibitor. Which is first-line therapy for someone with acute systolic heart failure. So acute systolic heart failure. Doesn't matter how far he's able to walk, because it's saying what's the first-line therapy for any heart failure patient. If they were to ask you what class of heart failure this guy's in, he's able to walk 5 blocks. So very minimal problems. So this would be a New York Heart Association Class 2 patient. Regardless, first-line therapy for someone with acute systolic heart failure. Amlodipine, dig, Lasix, lisinopril. In just about every case, the first-line therapy is going to be lisinopril. So why is it lisinopril? So the question is, what happens with acute systolic heart failure? So systolic heart failure is our left ventricle. Our left ventricle is not pumping very well. A normal ejection fraction for a left ventricle is about 50 to 55%. This guy's left ventricle is pumping less than that. So let's say he had an MI or may have a non-ischemic cardiomyopathy like Takotsubo or whatever. His ejection fraction is, let's say, is now 30%. So instead of the heart squeezing 50 to 60% of its volume out, it's only squeezing half that. It's only squeezing 30% of the volume out. We need to reduce the resistance that the heart pumps again. I tell my patients that when you think of heart failure, your left ventricle is a muscle, all right? And it has to push against the weight. Just like if you were trying to increase the size of your biceps, you put some, dumbbells and you do arm curls to try to get your biceps bigger, okay? The dumbbells is the resistance. If your arm is piddly weak, you're not going to be able to curl 50 pounds. If you got big, massive arms, you should be able to curl 50 pounds quite easily. So if we're struggling to curl 50 pounds, if we can reduce that weight to 25 pounds, we'll have a lot more success in getting more reps, right? So the resistance for the left ventricle is blood pressure. And which of these is going to be most effective at reducing blood pressure is lisinopril. Now, some people can make the case that in the African American population it should be amlodipine or Norvasc because that works pretty well for that population, and it does. And in certain instances, yes, that would be more of a first-line drug to use. But this has no mention of their ethnicity. So, random dude off the street with acute systolic heart failure, you can't assume what their ethnicity is, and we would choose lisinopril as being the drug of choice. All right, and that ends question 20. We'll go ahead and proceed next time with 21 through 25 and end this thing. Thank you so much.